Primary immunodeficiencies. An immunodeficiency describes a number of different types of conditions. You can have a defect in any part of the immune response. One or more of the components of the immune system can malfunction. You can have partial or total loss of immune function, and it can prevent the system from protecting the host from a potential threat. There are a couple different types. We can have primary or secondary. Primary is usually something that you're born with, a congenital defect. It's usually an issue with the lymphoid or myeloid lineages, and a defect in a single gene or a complex of genes can cause problems. There can also be some organ development issues with this as well. A secondary issue is different in the fact that you would acquire it from somewhere else. We've all heard of AIDS. That is an acquired immunodeficiency syndrome, that you get it from somebody else. You're not born with it. We can have malnutrition from not getting the proper nutrients. Sometimes radiation exposure can cause issues with our immune system, and even taking immunosuppressive therapy. So we're going to take a look at some of the different conditions, and whether it be congenital or acquired, that may cause some of these problems. The first one is an antibody deficiency. We've been learning about antibodies quite a bit this quarter, and you know that they're needed to help fight off an infection. It's the first thing that happens usually before complement comes into play. So if you're deficient in immunoglobulin, you're obviously going to be very predisposed to getting infections and things like that. So some of the different types include having a B-cell maturation defect. We call these agamma-globulinemias. A meaning without, gamma-globulinemia meaning antibodies in the blood. So an agamma-globulinemia means you're missing antibodies. This can occur at any step in the development of a B cell, anywhere from the stem cell to the plasma cell. We can have a defect in signaling molecules, which are needed for B cell function. We can have a defect in an isotype switch, which can affect the production of any immunoglobulin type. And this usually increases our pyogenic or pus-forming infections. This is not to be confused with pyrogenic, which is for fever, but pyo means pus. So we see big issues with those types of infections for sure. The treatment is usually a passive transfer of immunoglobulin. So if you've heard of people who maybe donate plasma at BioLife or something like that, that would be taking the immunoglobulin of one patient and actually injecting it into another patient. The next one is a selective IgA deficiency. This one's most common in the Arabians and the European descent, and it can vary from population to population. In most cases, we see this in more males than females. It's a chromosome 18 abnormality. There's an HLA, B8, and DR38 that are associated. You do not have to memorize those. And in general, as you would probably imagine, we see a low immunoglobulin A. Usually it's pretty asymptomatic. People don't really know they have it. There may be a family history, but we can have unexplained recurrent respiratory and GI infections. We can see allergic conditions and sometimes autoimmune disorders as well. For this, we usually treat the infections that come along with it, but we do not give the immunoglobulin injections that I just mentioned. IgA is very effective at mucosal interfaces, so it's part of the tears and saliva, and an injection of IgA would cause IgE to IgA. It wouldn't necessarily replace it and work very well. Having this deficiency isn't necessarily catastrophic. Most of them are asymptomatic, so you don't know you have it. You just get sick a little bit more often. And we do see a compensatory mechanism come along. Your body will actually start to secrete IgM levels, or increase the IgM levels. We see collagen vascular disease, allergic disorders, milk intolerance, autoimmune disease, and some malabsorption problems as well with this. The predominant type is an extravascular secretion. So we have an enormous surface area in the mucosal system, obviously. So the portal of entry for many pathogens would come through that way. We need that to protect us from pathogens. We also have that mucosal system in our GI tract, which is why we see issues there. We can have some mild to severe type of symptoms. Mild would just be respiratory infections, some diarrhea, digestive issues. And severe might be permanent damage to the airway or anaphylaxis with blood transfusions. The next one is a hyper IgM syndrome. We see different immunological malfunctions with this, and in this case we usually see a very increased IgM, but very low everything else, IgG, IgA, IgE. There's a defect in the isotype switching with this. The switching requires T cell to help, and there's a failure in switching that's usually due to a defect in T cell, B cell interactions, and actually the rearrangements of isotype genes can cause problems. So with this, we do see, severe symptoms like Bruton's agammaglobulinemia that we're going to talk about in a minute, and recurrent infections. So they'll have ear, throat, chest infections, diarrhea, even osteomyelitis, which is a bone inflammation. We treat this with gamma globulin replacement therapy. So they're going to give those patients IgG, IgA, IgE, and we're going to try and manage those infections as best we can. The next one is a common variable immunodeficiency. So this is from a variety of different immunodeficiency mechanisms. There's 20 to 30 different primary immunodeficiencies. This is a pretty severe clinical condition, and it's rare but the second most common primary immunodeficiency. We see very low levels of IgG, IgA, and or IgM. It's very susceptible to infections, just as all of these are. Lungs, sinuses, ears, get pneumonia, GI infections, even shingles. And we also have associated with autoimmune disorders with this, which we haven't seen with the other ones. We see hemolytic anemia, thrombocytopenia, and this is because the B cells are normal, but they don't develop into the plasma cells. In most cases, the CD27 positive switch memory B cell is drastically reduced. We treat these with immunoglobulin IVIG. Also infection control, when they do get the infections. The next one is X-linked agammaglobulinemia. So A meaning without, gamma globulins, we talked about that earlier. It's also called Bruton's agammaglobulinemia, or Bruton's disease. This usually occurs in males, about 1 per every 250,000, and we see a lack of mature B cells. Pre-B cells in the bone marrow lack the circulating B and plasma cells. So obviously impaired B cell development. There's going to be a lack of lymphoid tissue. We're going to see a lack of tonsils and lymph nodes as well. So lack of immunoglobulin of all isotypes. Okay, so not just one type, but all of them. The T cells, natural killer cells, CD4, CD8 cells are all normal. Okay, but this is going to affect the B cells. And we do see a congenital defect in enzymes. A lot of infections early in life. Once the mom either stops breastfeeding or those maternal antibodies are cleared out around 3 to 9 months, that's when we start seeing the infections and stuff start to creep in. They're going to have a lack of tonsils. So the doctor's going to notice that too, like, why is this child sick but doesn't have any tonsils? Usually they're localized, but they could be as big as systemic type of infections. Pneumonia, a lot of ear infections, otitis. Gastroenteritis, osteomyelitis, the bones again, a lot of bladder infections, meningitis maybe. We see cellulitis and skin abscesses, even enteroviruses like poliovirus and things like that as well. And this one's usually not catastrophic and you can live into your 40s, but we do try to treat this with the IVIG again. They treat infections very aggressively. Again, they find this after the mom's antibodies are cleared out. Our next one is DiGeorge syndrome. This is a T cell deficiency. The last ones we talked about were mostly B cells or variable. This is a small deletion of a chromosome that can affect organs and different body parts. We see heart defects, neuromuscular problems, palate defects, learning disabilities, aberration in facial expressions. I do have a picture down in the bottom right here that shows what a person with DiGeorge would look like. Now, some of the other symptoms, we didn't actually see any physical deformities or mental impairments, but with this one we do. We see a lot of childhood infections and a very dysfunctional thymus. Thymus doesn't develop normally. And we know that T cells affect other cells. Okay, they're kind of like controlling the other cells. There's a CD40 ligand defect that is a T cell defect, which of course affects the B cells because you need the T cells to tell the B cells what to do. Usually we see that failed third and fourth pharyngeal pouch of the thymus. So they're going to see kind of some atrophy there. It's not going to be normal. You can do a thymus transplant for complete DiGeorge. Usually they'll be stillborn at about 15 weeks if it's pretty severe. Next, we'll look at an enzyme deficiency, purine nucleoside phosphorylase deficiency. There's a purine salvage pathway. It degrades and converts respective metabolites, and if it's defective, we get a GTP buildup, which can be toxic to T cells. We then see impaired cell-mediated immunity. Very rare. We see it in the infants. There's going to be an actual decrease in T cells due to this toxicity of that deoxy-GTP. We'll have normal B cells, but again, you need the T cells to kind of tell the B cells what to do. Impaired cell-mediated immunity, obviously, because the cells aren't communicating effectively. A lot of opportunistic infections, and this one goes along with some of those autoimmune disorders as well. We see lupus, hemolytic anemia, idiopathic thrombocytopenia, and abnormalities of the nervous system, such as mental retardation, kind of like we saw with the DiGeorge. The humoral responses are not affected, so antibody levels are usually normal. We still have that B cell function. It's a severe T cell defect because of the enzyme deficiency. Next, we have some severe combined immunodeficiencies. So if you thought some of those were unfortunate, here's where we get very unfortunate. We're going to cover a few of these, but I have a couple other listed here as well. The first one is the adenosine deaminase deficiency, the one that I have first. We're going to refer to that as ADA. ADA is a defect in the gene encoding for the enzyme called purine and the purine salvage pathway. We see this with chromosome 20. And ADA normally breaks down adenosine. With this, we see the failure to break that down, which results in a buildup. This is toxic to immature B cells and T cells. It's an autosomal recessive problem, so you have to get 2 copies, one from each parent, in order to express the disease. T cells are very affected, more so than B cells. We see very small underdeveloped thymus, a severely compromised immune system, and the treatment for this is bone marrow transplant or gene therapy. So it's quite serious. The next one is Reticular DIS Genesis. This one is rare. We see low lymphocyte counts. We see a lack of blood monocytes and neutrophils, and usually the most severe form of severe combined immunodeficiency here. Life expectation is not great. This one may be something you guys have heard of. Xlinked severe combined immunodeficiency. If you've ever seen any of the movies, The Bubble Boy, I know John Travolta had one back in the 70s called the Bubble Boy, and there was one that's a little more recent. I think it came out in 2001. That is one that you may be a little bit more familiar with. This one is still very rare, but it is the most common. We have very low T cell and B cell lymphocytes. There's severe susceptibility to infections from infancy, so they have actually put kids in a bubble. There's a story about David the Bubble Boy, which is what these movies are based off of, and because he was so susceptible to infections, they tried to have him live in a bubble. The only treatment for this would be a bone marrow transplant or gene therapy. We can also have complement deficiencies. Obviously, we've spent a whole entire chapter on this, so we kind of beat that one to death. But as you can imagine, if you're missing one piece of the pathway, the rest of the pathway is not really going to occur. Okay? So if you have a defect or a deficiency of any of those pieces, it's obviously going to affect the end result, and you're going to have increased infections. Some of the more common ones, if you have a C3b defect, you're going to have obviously inefficient opsonization. Okay, those phagocytes are going to have a hard time finding those cells. If you have a C3 deficiency, that is really bad. Very high rate of morbidity. That is a key role in the pathway, right? You could have a defective lytic pathway, so if you have missing C5 through C9, you'd be more susceptible to like Neisseria, which would be like meningitis. In the classical pathway, you're very susceptible to issues as well. And in lupus, we see high risk. Then we've got 2 defects in phagocytic function. One of them is chronic granulomatous disease, and the other one's leukocyte adherence deficiency. So these are the 2 we're going to finish with. So chronic granulomatous disease is an aberration of phagocytes' ability to form the reactive oxygen species that's needed to kill ingested organisms. So once a cell takes in, let's say a bacterium or something like that, it needs to have a certain process take place to kill those microorganisms? Well, with this disease, there's a failure to produce the hydrogen peroxide inside the cell that's needed to kill the microorganisms. We see a lot of pneumonia, skin abscesses, arthritis, things like that. We use the nitroblue-tetrazolium test for this one. And one of the ways that I remember this, and I don't know if it'll help you guys or not, but when I was a kid, my mom would always put hydrogen peroxide on my knee when I fell off my bike. It had all that, if you ever fell on gravel, and if you look at your hands, if you look at your knees, and all those little pieces of gravel in it, she'd pour on the hydrogen peroxide to get out all of that granulomatous material. Granted, it's not called granulomatous material, but in my eyes, that's what it looked like, just gravel and junk. Pour on the hydrogen peroxide to clean that out. That's how I memorized chronic granulomatous disease. Obviously, there's not a correlation between the two. It's just a way to help you remember. Okay, last one here is leukocyte adherence deficiency, or LAD. This is an autosomal recessive genetic trait. And with this, the immune cells are not working to be able to phagocytize things. So usually, immune cells are moving all the time. They're essential for immune response. They know where to go. There's chemotaxis that tells things what to do. It's mediated by molecules on the cells. There's usually some type of a chemical Velcro that happens. Well, with leukocyte adherence deficiency, we see major recurrence of bacterial infections because there's issues with that cell locomotion. So we have lung issues, peritoneal cavity issues, gingiva, which is your gums. We see abscesses, and where they usually notice it is the umbilical cord doesn't fall off like it should. And that can be life-threatening because you can get an infection there, but it doesn't break off. Phagocytes have very defective integrin molecules, so they can't work to phagocytize things. They can't migrate through vascular walls to the site of infection, and they can't destroy invading microorganisms. So not being able to adhere to things is obviously a big problem. Treatment is a bone marrow transplant or some type of gene replacement. So that includes all of our primary immunodeficiencies.